It's time for the 3-question warm for Immunology 6. Let's get going. What gives rise to the jugular venous A, C, and V waves? So remember, the A wave is atrial contraction, the C wave is ventricular contraction, and the V wave is atrial filling against the closed tricuspid valve. Next question. Which heart murmur is associated with weak pulses? So this is aortic stenosis. Sometimes this is called pulsus parvus et tardus, which is Latin for weak and delayed pulses. Next question. What findings are associated with Ehlers-Danlos syndrome? So depending on the types of collagen that are affected, you can see things like easy bleeding or bruising. You can have hyperextensible skin. You can have joint hypermobility. And because of all this, there might be dislocated joints. That could also be aneurysms like aortic aneurysms or baryaneurysms as well. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to discuss hypersensitivity and complement, which may not be terribly exciting, but unfortunately, it's very high yield. For instance, hypersensitivity reactions are at least 4 stars, possibly 5 stars. There are 4 basic types of hypersensitivity reactions, which, imaginatively enough, are called 1, 2, 3, and 4. Type 1 hypersensitivity occurs when free antigen in the blood or on the mucosa binds to IgE on the surface of pre-sensitized mast cells and basophils. And that causes those mast cells and basophils to degranulate and release preformed molecules of vasoactive chemicals like histamine and bradykinin. These are vasoactive amines, so they cause vasodilation and increased vascular permeability, which allows fluid to leave the vessels and to get into the tissue, which then leads to local edema. This is called a wheel and flare reaction, or urticaria, which is commonly called hives. And because these vasoactive amines are preformed, this reaction can occur very, very rapidly. The classic example of a type 1 hypersensitivity is anaphylaxis, like an anaphylactic reaction to a bee sting or peanuts or other foods. So technically speaking, if you say someone is allergic to a medication or food, you're talking about an IgE-mediated phenomenon. If they have a reaction to a food or medication, but it isn't IgE-mediated, you really should not call it an allergy. You might say they're sensitive to it, but they're technically not allergic to it. Another example of type 1 hypersensitivity would be atopic disorders, such as asthma, allergic rhinitis, like hay fever, and eczema. Even though eczema does have a T cell component to it, it's still considered a type 1 hypersensitivity. If you want to determine whether a patient has a type 1 hypersensitivity allergic reaction to something, you could do a skin test or a scratch test. This is usually done by allergists. They prick the skin on the back with a needle a bunch of times, and they put common allergens into those holes. And then they watch to see if the patient develops urticaria. Type 1 hypersensitivity occurs fairly rapidly, so urticaria develops within about 15 minutes. Type 2 hypersensitivity occurs when there are antibodies against cellular antigens. Antibodies bind to cellular antigens and activate the immune response. So this might lead to a complement-mediated damage, or the macrophages may phagocytose the cells, or NK cells may attack and destroy antibody-coated cells. But the main thing is to remember that it started with antibodies against cellular antigens. Specific examples of type 2 hypersensitivity would be autoimmune hemolytic anemia, where you make autoantibodies that attack your own red cells. Another example of hemolysis caused by type 2 hypersensitivity would be acute hemolytic transfusion reaction, where the patient has type A blood and you accidentally transfuse type B red cells, and the patient's anti-B antibodies attack the B surface antigens on the donor cells. We'll talk about that more in a moment. There's also erythroblastosis fetalis, where a pregnant woman's IgG antibodies cross the placenta and attack the fetus's red cells. An ITP, immune thrombocytopenia, they're autoantibodies that attack platelets instead of red cells. Another type of anemia caused by a type 2 hypersensitivity is pernicious anemia, where the autoantibodies attack the parietal cells of the stomach, which produce the intrinsic factor. And there are also autoantibodies against the intrinsic factor itself. Without intrinsic factor, the patient can't absorb vitamin B12 in the terminal ileum, and that leads to B12 deficiency, which then causes anemia and peripheral neuropathy. Myasthenia gravis is a disease where there are autoantibodies directed against the acetylcholine receptors of the neuromuscular junction. Another neuromuscular disease caused by autoantibodies against cellular antigens is Guillain-Barré syndrome, in which there are autoantibodies against the Schwann cells, which leads to demyelination of the peripheral nerves. Graves' disease occurs due to antibodies against the TSH receptor. In pemphigus vulgaris, you have antibodies against the desmosomes or protein desmoglein. Bullous pemphigoid is caused by antibodies against the hemidesmosomes. Goodpasture syndrome is where you have antibodies against the glomerular basement membrane. And acute rheumatic fever is a hypersensitivity in which antibodies against group A strep start attacking the host. Let's move on to type 3 hypersensitivity. Type 3 hypersensitivity is when there are antibodies against soluble antigens, not cellular antigens, like in type 2 hypersensitivity, but free-floating antigens that are then dissolved in the blood. These antibodies bind to the soluble antigens and form antibody-antigen complexes that then get deposited into the tissues. So this isn't really antibodies attacking cells that causes the problem. It's the antibody-antigen complex getting into the tissue that causes the problem. And again, these immune complexes evoke an immune response with activation of complement and recruitment of neutrophils and ultimately a lot of tissue damage. Examples of type 3 hypersensitivity reaction include lupus, rheumatoid arthritis, polyarteritis nodosa, and streptococcal glomerulonephritis. Another example is serum sickness. When you hear serum sickness, I want you to think about antibody-mediated drug reaction. In serum sickness, you produce antibodies to foreign antigens, like drugs. Most drugs aren't proteins, but the drug acts as a hapten, which is a molecule that gets around by a carrier protein, and then that hapten protein complex can bind to antibodies and form immune complexes. So again, serum sickness is an antibody-mediated drug reaction. It's called serum sickness because back in the old days, the pre-antibiotic era, they used to have things like scarlet fever or diphtheria that they would treat with horse serum that contained a bunch of antibodies against the toxins. But after a week or so, some of the patients would start making antibodies against antigens in the horse serum. And those antibody-antigen complexes would then deposit in the tissues, causing fever, rash, urticaria, arthralgias, and proteinuria. So again, nowadays we see drug reactions, but they cause a much milder form than this. One last example of a type 3 hypersensitivity is called Arthus reaction. This is a local subacute reaction where you give an intradermal injection of some antigen, like a vaccine, and then the antigen-antibody complexes get deposited locally in the small vessels around the skin, leading to activation of the complement and local edema, and then tissue necrosis. This Arthus reaction usually occurs 4 to 12 hours after the injection. So it's not as rapid as a type 1 hypersensitivity, but it is a lot more rapid than serum sickness, which takes several days to develop. And then there are type 4 hypersensitivity. This is T-cell mediated. There may be antibodies involved, but ultimately it's caused by the T cells. T cells bind to antigens and then release cytokines like IL-2 and interferon gamma. And those cytokines activate macrophages, and that causes tissue damage. The two buzzwords I want you to remember with type 4 hypersensitivity are delayed hypersensitivity and cell-mediated hypersensitivity. Whenever you hear delayed hypersensitivity, I want you to think of a type 4. And it's delayed because of cellular immunity, and cellular immunity takes a while to get ramped up. It's not like type 1, where you have the antibodies lying around ready to go. With type 4, it takes time to present the antigen to T cells, and then they have to make the cytokines, and then the macrophages have to be recruited. It's a delayed process. Think about poison ivy. It doesn't start itching immediately, it takes some time. Or think about the PPD skin test for tuberculosis. When do you read the PPD? 48 hours after it was given. So some examples of type 4 hypersensitivity would include the PPD skin test, which we just mentioned, Hashimoto thyroiditis, which does involve several antibodies, but it's primarily T-cell mediated, multiple sclerosis, graft versus host disease, where you have a bone marrow graft and the T-cells from the donor bone marrow end up attacking the host. Also contact dermatitis, which includes things like poison ivy, poison oak, or some types of latex sensitivity, although latex can be a true IgE-mediated allergy, or it can cause type 4 hypersensitivity. You can also get contact dermatitis from metals or nickel or cobalt. The big clue from contact dermatitis from nickel is that you see it in areas of the skin that are exposed to nickel. So there might be dermatitis on the wrist from a watch band or the ear from earrings. Or in this photo, there's nickel in the button of the patient's jeans, and right where it's rubbing the skin, it's getting contact dermatitis. So it's usually pretty easy to recognize. I mentioned that a certain type of transfusion reaction as being a type 2 hypersensitivity. But transfusion reactions are not all created equal. There are several different types of transfusion reactions, so let's review those. The first one is an urticarial reaction. This is a minor allergic reaction in which the patient has IgE antibodies against soluble antigens in the donor plasma, and it causes some urticaria, hives, and itching. So, which type of hypersensitivity reaction is this? It is IgE mediated, so it's type 1. You treat this by stopping the transfusion and giving Benadryl. This is an allergic reaction, so treat it with an antihistamine like diphenhydramine or Benadryl. And this is the only type of transfusion reaction that is insignificant enough to continue the transfusion with the rest of the bag. If the urticaria resolves with diphenhydramine, go ahead and continue that transfusion. Now, anaphylactic transfusion reactions are also IgE-mediated type 1 hypersensitivity reactions. So this often occurs within minutes of starting that transfusion. With anaphylaxis, the patient can have shock and hypotension, sometimes angioedema and respiratory distress. This is life-threatening. And that's a major difference between urticarial reaction and anaphylactic reaction. Urticarial reactions are fairly common and mild, while anaphylactic reactions are severe and much less common. The mechanism's the same, but the difference is the severity of the reaction. We don't really understand why some of these patients get severe, life-threatening reactions and others basically have some minor hives. But one classic association is that patients with IgA deficiency are at an increased risk for the anaphylactic reaction. They can make anti-IgA antibodies. So the first time these patients receive a blood product, if there are any traces of IgA in the donor blood, the recipient will recognize that donor IgA as a foreign substance. They'll then form IgG and IgE antibodies against the IgA. Now the next time they receive a transfusion, those new anti-IgA antibodies will attack the traces of IgA in the donor blood, and they will get an anaphylactic reaction. This is a well-established mechanism for anaphylactic transfusion reactions. But most of the time, anaphylactic reactions aren't due to IgA deficiency at all. But it is a classic association, so it might show up on your test. And then for treatment, we give epinephrine, IV fluids to bump up that blood pressure, and oxygen. Sometimes you may even need to intubate them. The most common type of transfusion reaction is a non-hemolytic febrile reaction. It was originally thought that this was due to antibodies against the human leukocyte antigens, HLA, on white cells that was found in the donor blood. But now it's thought that this reaction is caused by cytokines that are generated by cells in the blood while it's in storage. When the blood gets transfused, those cytokines are transfused too, and this causes a fever beginning 1 to 6 hours after the transfusion. You might need to update your book on this one. This is not thought to be type 2 hypersensitivity any longer. So again, there's no hemolysis, just fever, chills, and malaise that begin within 1 to 6 hours of the start of the transfusion. And you treat it with acetaminophen, just as any other fever. A much less common reaction is the acute hemolytic transfusion reaction, which is usually due to ABO incompatibility. This one is a type 2 hypersensitivity, where circulating antibodies bind to the cellular antigens on the donor cells. And the main reason for an ABO compatibility is clerical error. The patient was O negative and you gave A positive blood because of a clerical mistake somewhere along the way. This is an acute reaction, so it has an onset during the transfusion, within 1 hour, not hours or hours later. The reaction is characterized by severe antibody-mediated hemolysis, leading to fever, chills, tachycardia, tachypnea, and hypotension. The treatment here is aggressive supportive care. The last one I want to discuss is called transfusion-related acute lung injury, or TRALI. This occurs in individuals who have some kind of damage to the pulmonary vascular endothelium, and neutrophils are kind of sequestered in the lungs and primed. When you transfuse the blood products and anti-neutrophil antibodies from the donor activate the neutrophils in the recipient, they release the cytokines and reactive oxygen species and proteases, all that cause pulmonary vascular endothelium to become very leaky. The patient then develops acute pulmonary edema, shortness of breath, usually within 1 to 2 hours of starting the transfusion, maybe up to 6. This is pretty rare, but it is also very severe and is the leading cause of transfusion-related death. These patients need to be intubated, mechanically ventilated, and hemodynamically supported if they develop hypotension. Now, let's talk about complement. The complement system is basically a group of plasma proteins that work together to complement the actions of the immune system by opsonizing and killing pathogens and clearing them out of the way. The good news is you don't need to memorize the entire complement pathway for step 1, but I'm going to review a handful of key things that you should know. First of all, you need to know the 3 pathways of complement activation and what stimulates each pathway. The classic pathway is stimulated by an antigen-antibody complex. Remember, one of the ways that type 3 hypersensitivity reactions cause damage is by activating complement. So that's the classic pathway. IgG or IgM antibodies bind to an antigen and then to a C1 complement protein and activate it. There's also an alternative pathway which does not require antibodies. Complement can be activated by molecules on the surface of microbes, or complement can spontaneously activate itself. There's also the lectin pathway. A lectin is a protein that can bind to a sugar. So, in the lectin pathway, a specific lectin protein called mannose-binding lectin binds to the mannose sugar molecule on the surface of the microbe, and that activates the complement cascade. So, definitely know the initial steps for each of these pathways. The second point I want you to know is that C1 is the starting point for the classic pathway. That's the second time I've said it in the last 45 seconds, so it's probably worth remembering. And there's a specific enzyme called C1 inhibitor that inhibits the cleavage of C1 into active components. And don't get confused, because C1 inhibitor also goes by the name C1 esterase inhibitor. The third major point about the complement pathway that you should know is the very last step, which is the formation of the membrane attack complex, or MAC. The MAC is the end product you get from activating complements. It's a complex of several complement proteins that all get inserted into the plasma membrane of the cell one by one, creating a hole in the plasma membrane and then killing the cell. The specific complement proteins that come together to form the MAC are C5b, C6, C7, C8, and C9. Those are also worth knowing as the components of the MAC. Let's walk through a few more details about some of the individual complement proteins. C3b is important for opsonization, which is basically the process of coating pathogens so they're more likely to appeal to the phagocytes. It's kind of like dipping the pathogen into a chocolate fountain. It doesn't matter what the antigen is. When you dip it in the chocolate fountain, those phagocytes are much more likely to eat it. That's particularly important when it comes to destroying encapsulated bacteria. So patients who are deficient in C3 are more susceptible to encapsulated bacterial infections. We also mentioned that IgG antibodies can opsonize pathogens, so So C3b and IgG are the two most important opsonins. C3a and C5a play roles in anaphylaxis. To be more specific, C3a stimulates mast cells and basophils. And remember what we talked about? How mast cells and basophils release histamine, which causes vasodilation, increased vascular permeability, and it allows the fluid to flow through those vessels, which can lower the blood pressure and lead to anaphylactic shock. That vascular permeability also leads to edema and swelling of the larynx and the tongue, which is why the throat feels like it's closing up during anaphylaxis. And C5a is also involved in neutrophil chemotaxis. Let's talk about some diseases in which the complement system doesn't work correctly. If there is a deficiency of the C1 esterase inhibitor, that causes hereditary angioedema. We don't really understand how or why this works, but it seems to have something to do with an elevated bradykinin. Angioedema in general is bradykinin mediated, and somehow deficiency of C1 esterase inhibitor results in elevated bradykinin. And these patients should never take ACE inhibitors because ACE inhibitors also increase bradykinin level and can cause angioedema as a side effect. Deficiency of C3 leads to recurrent pyogenic sinus infections and respiratory tract infections, specifically those encapsulated bacteria like strep pneumo and Haemophilus influenza. These patients also have increased susceptibility to type 3 hypersensitivity, especially glomerulonephritis. Basically, C3 is needed to opsonize and clear out those antibody-antigen complexes that cause type 3 hypersensitivity. So no C3 means more type 3 hypersensitivity. Deficiency of C5b, C6, C7, C8, or C9 means you can't form the membrane attack complex. So deficiency of any of those will predispose to Neisseria bacteremia, both gonococcal infections and meningococcal infections. And there's also deficiency of decay accelerating factor, or DAF, which is also called CD55. DAF is a substance that helps to protect your own cells from complements that have spontaneously activated itself through the alternative pathway. So DAF deficiency leads to red cell lysis and a condition called paroxysmal nocturnal hemoglobinuria, or PNH. Take a look in your study guide and let's talk about PNH for just a moment. PNH occurs in individuals whose red blood cells are deficient in two surface molecules that are involved in protecting the cell from destruction by the complement in the MAC. The first is a glycolipid called GPI, or glycosyl phosphatidylinositol, which is a molecule that anchors various cell surface proteins to the plasma membrane, including decay accelerating factor, or CD55. The second surface molecule that's missing in these patients is called MAC inhibitory protein, or CD59, which also prevents the membrane attack complex from destroying cells. So, if you don't have those two molecules, CD55 and CD59, you can get complement-mediated damage of the red blood cells. So your red blood cells are being attacked and lysed by complement, which leads to chronic intravascular hemolysis. And then the hemoglobin in the red cells ends up in the urine and causes hemosideruria and red coloring in the urine, which is a classic finding. Another unique finding in PNH is thrombosis, because platelets also get destroyed and they release their prothrombotic components. Now, how do you diagnose PNH? There are two tests to be aware of. Historically, we used a test called Ham's test, which is where you put the patient's red cells in acid. And if they lyse at a very low pH, that's a positive Ham's test, which is diagnostic for PNH. A more common, more modern way of making the diagnosis is to do flow cytometry. Flow cytometry allows you to look for the presence of CD55 and CD59 on the surface of a red cell. If you do flow cytometry and you don't see those surface markers on the red cells, that suggests the diagnosis of PNH. So how do we treat it? These patients need transfusions because of the hemolysis. We also anticoagulate them with warfarin because of the risk of thrombosis. And then there's a drug called eculizumab, which is a monoclonal antibody that inhibits complement and prevents it from attacking red blood cells. But eculizumab costs several hundreds of thousands of dollars a year. All right, now we're ready for the end of session quiz. So work through those questions and then we'll talk through the answers. First question, which type of hypersensitivity is responsible for the following clinical problems? Post-streptococcal glomerulonephritis. That's a type 3 hypersensitivity. What about asthma? Asthma is type 1. And rheumatic fever? That's type 2. A TB skin test? That's type 4. Allergies, anaphylaxis, and hay fever? That's type 1. Polyarteritis nodosa? Type 3. Serum sickness? Also type 3. ABO blood type incompatibility? That would be type 2. Poison ivy is type 4. Eczema is type 1. Contact dermatitis is type 4. And Goodpasture syndrome, that's type 2. Now, what about a patient who suffers from recurrent infections? What complement proteins could they be deficient in? This could be any of our membrane attack complex proteins, C5b, C6, C7, C8, or C9. Last one, which complement is responsible for neutrophil chemotaxis? That is complement C5a. That's it for this video. I'll see you next time.